So what I had was actually a series of cases to present, three of which were for patients that actually were in my clinic who had failed random call-ins in various ways. And then there were three sort of generic cases that didn't actually happen recently, but have happened many times over the years. There were also ways that randoms were failed. And so the presentation I had was, the goal of it was really to get feedback on how WVU handles the complexities of all the excuses that you get for why the randoms fall out the way they do. It's very rare that you have a situation that's cut and dry, failed random. You get a lot of so I've kind of organized the generic cases into three categories of ways to fail a random call-in. The first category would be like they either don't show, or show up late. The next category would be they show up, but there's something wrong with their wrapper counts. They have some shady story to explain it. Maybe it was lost or stolen. And the third one, it would be like they come, or they get called. They say they'll come, but then they have, or maybe they don't say they'll come. They have some elaborate reason why they can't make it at all. So these are sort of the three, I would say, ways that I've seen people to fail a random. And so it puts the care managers in a situation where they don't know. This person showed up 24 hours. If they show up 25 hours after the phone call, we probably just shrug it off and we don't worry. But when is the magic moment? 48 hours, if we start to say, well, okay, then but probably beyond that, it's hard to say it's okay. We call it a failed random. But then what if they have a really amazing excuse? And so it ends up like a rabbit hole that you keep going down trying to find out. Well, should we count this as a failed, or we should count this as an excused failed random? So I'm going to try to present the three specific cases from memory that we've had recently that fall into some of these categories. But actually, I think before I present those cases, because I'm trying to work from memory, I'll just go ahead and open it up to, like, in generic terms, any feedback you all have regarding those three overarching categories. Is that what you all also see when you all are calling people in for randoms? And you already have some pretty nice systematic ways that you're dealing with it before I get into the specifics.
I'm going to throw that out to the whole group if people have developed.
Right. So are you guys just in general just doing them individually, deciding whether to count something as an excused or not excused, or do you have some protocols in place that prevent some of this from happening?
So this is probably the best answered by Douglas, but he's not on the call. So the most important thing is that you are consistent within your system. And so, one of the things that we've talked about is, this is the model, and the model can be adapted to people's specific settings and systems. And so internal consistency is the most important thing, so that you treat every patient who shows up under that particular scenario with that particular presentation the same. So the case managers typically handle these. It does depend a little bit on, sometimes they're random, sometimes they're random with cause. So there's random, and then there's random with cause, as you may have experienced also. So we have some suspicion, or somebody has told us something, and we're not going to go on what somebody's told us, but we want to verify with some objective data that someone may not be, doing what they're supposed to be doing in clinic. So I got it. Phil, I don't know if you handle things out there, and Dr. Hirschler, if you know what Olivia does at Lakewood.
So Olivia will kind of follow our agreement with the 24 to 48 hours, and then every situation is treated the same. whether it's an excuse or it's not. All of the clients sign that whenever they first come out here, so they know what they're getting into when it comes to the random call-ins. And we kind of prep them, remind them throughout groups at different times that, hey, you guys are subjected to random call-ins. So make sure, you can always come ready to provide a urine, and you always bring your medication. So we try not to let them be blindsided by human error of forgetting. And so if they're without 48 hours, then it's, I believe the policy is they're sent to a higher level of care. Don't quote me because I don't have the agreement in front of me, and I don't have Olivia yelling at me that I said it wrong.
In my clinic, what kind of made me ask this question so generally is because I'm thinking about doing sort of a general warning like what you have there at Lakewood. And actually, I did it to a patient today that I oriented. I said, if you don't tell me that your meds were lost or stolen until the one day that I call you in for your random, and you don't have wrappers, I'm not going to think that that's lost or stolen medication. You should be calling me as soon as you realize they're lost or stolen. And so the probability that I would call you at the same time that you would get them lost and stolen should be very close to zero. Because you would not believe how frequently I've had someone, and I really think it was starting to become like a mulligan strategy for a number of my patients, where they knew that other patients had done this. Oh yeah.
Yeah.
And the other one they do, and it's not too different from lost or stolen, is I took it early, and I'm not telling you until now, even though I told you everything was just fine 3 days ago with my pain. I just took the medicine early because my pain flared. We see that a lot. So counting whether to count that as a failed random has been a bit of a challenge.
And if they're saying that they're lost or stolen, they typically have to provide a police report in order for anything to be done. So if they need medications, additional medications, they still have to pay for it out of pocket, but we need that police report stating that it was lost or stolen.
We use the police report to decide about whether we replace or not. We don't usually penalize them if they're not willing to file a police report. And so, except we don't replace it.
Correct. Yeah, that's
what we do
yeah.
too.
But I will say that it was probably at least 10 people, many of them in the far along group, who were failing randoms in this way, of either saying that it was lost or stolen, or that they took the medicine early. And we had one person do it twice within a few months, so that they came in, they're like, 10 wrappers short of where they're supposed to be in the month. And so they returned the wrappers, but they've been opened. So they're ahead of where they're supposed to be. So.
Yeah, I mean, that is a warning sign, right? So something's wrong with the way that they're taking their medication. So we would typically, in that case, have someone bumped up to coming more frequently, because it means they need a little bit more monitoring with taking their medication as prescribed. It doesn't have to be a punishment, but that is an indication that they are struggling to take their medication as prescribed, especially if it happens more than once.
Oh,
Yeah,
Dr. Morrison, I think you're muted. Sorry about that, Jeremy. I cut you off.
You can go ahead, Jeremy. I'll wait for you to say your thing.
Yeah, that's kind of what we do. What policies that we have is we have a 24-hour random callback policy, and if the clients don't come in, or they come in with a medication count being off, then we typically would move them back a level. So if they're in a monthly group, they go back to the 2-week group. If they're in a 2-week group, they go back to weekly. If they're weekly, we might call them in twice a week. We've gone down to daily. It's for some people sometimes, but just trying to help them back. But the way we don't try to make it feel like maybe a punishment is, it's not that they eternally have to stay at that 2-week group or down to the weekly. We'll let them know that we're definitely going to call them back in very soon at that new level. And then if they're able to remedy the situation and come back and get it fixed quickly, then they just move right back up to where they were. And usually they do, because they really don't like the inconvenience of having to come in more frequently than they're used to. So that seems to work for us. It doesn't work all the time. Usually if they fail 2 or more, then we'll discharge them from the program, or we'll maybe refer to a higher level of care. But that's rare that happens, at least for us.
So I think where I run into trouble is when they fail 2 or more is one of my biggest problems. Like we had this guy. I'll just use case 1. We'll make this an actual specific case so we can get a little bit of a context. A guy has been sober for a couple years, doing well, never had problems. But then we bust him, 10 wrappers short 1 month. We take him back to weekly from every month, and we do that for a month. Then we take him back to monthly, and we bring him right back in a couple weeks later. He's off on the wrappers again. So now I'm not sure what to do. Re-escalate back to weekly. It's actually what I ended up doing, feeling like maybe it wasn't enough. And then now there's a third situation where, like, we called for a random, but he had told someone that his phone was broken, so he feels he shouldn't be penalized for not responding. So there's a case. How would you guys go with that?
So again, if there's already objective evidence that they're struggling, and this is yet a third example of them not being able to do what you've asked them to do. I mean, we wouldn't move them from monthly to weekly, but we would move them from monthly to biweekly or biweekly to weekly. Just kind of one phase back up so that we can see them more often. But yeah, I mean, you have a little bit of a shorter leash on folks who have already recently shown that they're struggling to take medication as prescribed.
And you got a pattern with this guy, it sounds like. And I would probably do what you did as well, is just bump them down to a higher level of care more frequently. So again, like Laura said, for us, if they were in monthly, we'd have them come back to biweekly. If they were in biweekly, we'd have them come back to weekly, et cetera, et cetera. And you may end up having to keep him longer in your higher level of care than you would have otherwise. And you can just tell them, this is because this is what we're seeing, this is the objective evidence we have, and this is our policies. And so it's much easier to rely on the policies, especially if you're consistent with the policies with whatever you've developed, and let the policies do their job for you. Another option that you might want to consider with somebody who is just struggling with having 30 days worth of medicine is writing out a week's worth or 2 weeks worth of medicine and then putting a refill on there as well. So they're not having all of the medicine at once and are at risk to have that large amount in their hands at one time.
Because the other thing that we've seen happen, and this tends to happen more with women than with men, but can certainly happen to anyone, is people take their medicine and either take it permanently and so they don't have it at all, or try and manipulate them with it. So they don't always have control over their medicine, and they're not able to get out of that situation. Obviously, we would want them to get out of their situation, but if you feel like they're actually doing well and this is like not consistent with the behavior you see clinically, there may be something going on in the background that they may not have control over their medicine, or someone's taken half of it every month and they just are actually taking half their dose and we just don't know about that. So that's something to think about and maybe try and tease out if the patient is willing to share that.
Dr. Morrison, I think you might be muted again. Sorry.
The next person in my case series is a 58-year-old female who we threw out of our clinic a year ago for bringing back the wrong wrappers. We treated it as diversion. We do serial number cross checks. And but then we brought her back after the 6-month diversion ban, and she did well. She passed all drug screens and randoms for a year until last week when she didn't respond to a call in. She said she was in the hospital with her brother-in-law who's dying, and I guess she just didn't want to deal with this. And then we called her back a couple more days later, and she did agree to come in the same day. So that was 5 days from the time that she was called in. She did finally come in. Any ideas on what you all would do with that?
I don't make these decisions. So this is really a Douglas question. He's
We give our case managers a lot of power to decide what to do in these cases, just because the clinicians aren't always readily available, and sometimes they'll reach out to us and try to get some feedback as well. I'm thinking that in this circumstance is if she could bring documentation about the hospitalization from the brother to at least validate that, and also let her know that, well, right now you didn't come in, so I'm going to have to see you a little bit more frequently for a time, and or be on alert. This is your one warning. I'm going to be calling you in and randomly. So what's your number? Be ready to come in, whatever specified amount of time. If it's 24 hours, you're going to have to come in within 24 hours, and there's no excuses. If you're not, or you can't do that, then we're going to see you, weekly or a couple times a week or something like this. It's probably what I would do.
We can also, I'm just texting Douglas, he's not able to join us. We can also revisit this in 2 weeks when we have some additional case management here. Douglas can weigh in on what he would do, because I know he and Jordan typically handle most of these.
The other thing I would add too that we added over time was when someone does have an issue with a random count, we have them sign something for 2 reasons. We put it in the record. One is so that we remember and we can readily see how frequently it's happened in the past. And the second thing is that we give them an opportunity to explain the reason in writing. And then we try to remedy the situation right then. So if it's my phone's broke, then we make sure that they have a new phone for the next time. If it's something with transportation, that we all decide that if they get called into the future, maybe they can go to a different site or a different facility. They can come in at a different time after hours. That has also helped sometimes. That way, like I said, one, so we remember what the reasons were if it's been multiple times, and 2, that we did actually fix it in the past, so we're not just refixing the phone issue over and over again. So that seems to have helped too. So I don't know if it would help in your situation, but it's helped us a lot.
I like those ideas a lot.
Absolutely.
How do you help them with the phone? You buy them a new phone?
There's those phones that we can help them sign up for. We can help them get like the assistance phones if they need to sign up for one. If it's something to do with a repair or something, we have case management resources and care coordinators that somehow magically get people phones. I don't know, but they do it.
All right.
Yep.
I like it.
Yeah.
Any other strategies that people have used that they want to share?
This is Jennifer Boyd. I don't have a strategy. I just started as a prescriber in our MAT program at New River a week ago. And so everything is really new for me. It's really great to be on the call and learning from you all. I just want to make sure that I'm clear with the concern about not having enough wrappers. The obvious one to me is that, as was mentioned, they could be diverting, or somebody else could be taking their medication, putting them under pressure to take it. But is it also possible, am I understanding correctly, that they could be taking more than was prescribed?
Yes, absolutely.
And so what does that indicate? How do you handle that? If they're taking more than prescribed, do they need more, or why are they taking more?
So it could be a function of them actually needing more. I think it is a safe assumption that most of the patients who are coming in, especially early, will absolutely take more than what you're prescribing, because that's what addiction is if something is working or if something's helping me, then I must need more in order for it to really, really help me, okay? And so part of the challenge when somebody is coming in, especially early on in treatment, is helping them, helping reduce the anxiety and those patterns that have kept them in that vicious cycle before of continuing to try to take more of a substance in order to make them feel better. You know, for the doses that we're all prescribing, most of the time that's helping with their cravings and their urges, and certainly with their withdrawal. But when you're getting them in routine by seeing them frequently, if they're taking more and they run out, then they know that they're going to be at risk for getting sicker until they see you again. And so it's going to be important to assess that and not give them ongoing excuses to continue to take more between visits. It will be an opportunity, like you're already considering, to think about, okay, what is the appropriate dose when I see them? And you may be underdosing them, okay? I'm not sure what doses you're prescribing now, but the most common doses that we've been prescribing for a long time is 12 milligrams. And it would not surprise me if somebody's coming in and being prescribed less than that and are taking more during the time. And we don't prescribe more than 16 milligrams. And I think you're safe anywhere around 12 milligrams.
And so this question of not enough wrappers on a random, is that part of the conversation? Like, I'm just asking if they're taking more, and if so, why? And talking about that, if they're not having withdrawals or craving, then it's part of a habit of addiction.
Well, and you're right, and they'll probably say, I'm craving, or I am going through withdrawal, I feel like it's wearing off. And a lot of what I do constantly, especially early on, is help them understand, yep, that's a common experience. You're just starting, the medicine's just starting to work. We're trying to help you get engaged in these other elements, such as recovery meetings and the therapy, that's going to help you deal with the way you're feeling, and so that you don't have to turn to a higher dose or other medication or whatever to get through it. But it will get better over time with the structure and these other treatment elements that we're providing for you. And so I normalize that a lot.
Thank you very much.
Thank you. How about it for the rest of the group? How do you guys deal with that? What do you typically tell your patients when they've come in and they've told you that they're taking more than prescribed?
I'll speak to this issue. So it's usually more complicated than that they're just taking more than prescribed. Perhaps they're using some other illicit opiates, and so that may mean that their dose is inadequate. If they're not using any kind of illicit or prescribed opiate medications beyond the Suboxone, then I would think that their dose is probably adequate, and they just need to rein in this impulse.
Yeah, we do something similar. Also, similar to what you had described, and we just talked. It's usually not that they're taking more consistently; it's that they use the Suboxone like they're using any other drug. So they take it one day, they'll take 2 because they're going to have a bad day, or another day they'll take less because they think it's an easy day and they're full of energy. So we ask them, what does that sound like? And they usually say, well, it sounds like someone who's using drugs. I'm using the Suboxone like I would use something else. After we, kind of explain it that way, if they're like, you know what, yeah, I was misusing it in that way and I need to take it like a medication, typically that helps them start taking it more regularly, and they end up on time. If it doesn't and they're still reporting, the cravings and symptoms like that after they've made that change or we've had that discussion, then maybe we go up on the dose. So.
And in some ways, it's completely understandable. I mean, I don't know, about 85 to 90% of the folks that we see for intake are taking buprenorphine off the street. And so they're used to having a not consistent dose. And also, as Jeremy's saying, medicating mood. So we'll find in early recovery, it's very common for patients to say, I don't know, I'm not having withdrawal, but I'm so uncomfortable, or I'm so anxious, or this really bad thing just happened, and they don't want to feel the fallout of emotions when really bad things happen, because they're not used to having to experience difficult or uncomfortable emotions. And that's just really the process of early recovery, and helping them understand that that's completely normal, but it's also really important that you take only the amount that you're prescribed, because otherwise you'll run out. And I know what Dr. Marshalik says is the only way we can really figure out if you need to go up on your dose is if you're consistently taking the dose I'm prescribing. Then I can know, what you're experiencing when you're taking 4 one day and 12 the next day and 16 the next day, and then, you're all over the place. It's hard to know what the right dose is.
I always feel like I'm being blackmailed whenever I call someone in for a random and they say that they've taken their medicine early and they just need me to go up on their dose. I feel like it shifts the onus from they've used the medicine irresponsibly to I've prescribed the medicine ineffectively. And so I generally will not go up on the dose in that scenario.
Yeah, to be clear, I will never go up on the dose in that scenario. So if they're called in and they're short their medication and they say they've used more, I will never go up, and I won't provide them more, either. So yeah, for the exact same reasons. Otherwise, we're just encouraging people to take more and get called in and not have their medicine and then get more medicine. So I'll wait till the next visit or the next several visits to reassess.
One thing I learned from working with the methadone program is kind of a language around opiates to see if the medication is working for the patient well. And what I talked about is how it's holding them. That if they feel like the medication is holding them well, then they feel comfortable, and that's an adequate dose for them. I think you kind of develop a language about how to talk about how well the medication is working. And patients will say, I feel comfortable, or it's holding me pretty well, and then they'll kind of adhere to that dose. And if it's not holding them well, you'll hear kind of what the concerns are about why it doesn't feel right.
Dr. Morrison, I also wanted to say for the next session, we can make sure to have the case formatted, and we can revisit some of the questions from today for Douglas or a case manager, So we can certainly revisit all of this at the next session. I did want to give some time for the didactic as well. But before we do move on, I wanted to ask everyone out there, were there any comments, questions? You can feel free to chat us as well if your audio isn't quite working. All right.
Hey, I had a quick question. This is Dr. Carter. I was just at our admin and they're doing a lot of coronavirus prep. So they were wondering what we would do MAT patient wise if we had somebody come in that tested positive for it. Like say somebody's coming in daily and they test positive, would we give them a longer script, or how would you guys handle that?
What's coronavirus?
I have no idea. I wish I'd never heard it. I got a poster and everything while I was up there.
And do you actually have the ability to test for it? Because I don't think we do.
She said that they're going to be able to send it off to LabCorp, but it's like a 4 or 5 day turnaround. So by then, what's the
Everyone's
point?
fully infected.
Yeah. So I don't know. She just wanted to see if you guys had a protocol.
We don't.
Okay.
Yeah, I'll burst that bubble right now. Yeah, we
All
don't.
right. I figured I'd ask just so I could, cover my bases with admin.
So, like whenever someone is sick, we encourage them to use their cancellation.
Yeah.
If they do not have a cancellation to use, which they often don't, that presents a different kind of problem. We do offer people masks if they literally are coughing or sneezing. And so it's really the people who are sick that we need to wear the masks, not everybody else.
Okay. Yeah, that's what I kind of told them. They just wanted to see if we had a better answer.
Yeah.
That's what we
No, that is very true. We have had people come in really sick, and they've used up their one time get out of treatment free card, and we have masks available, and they'll sit there with the masks.
Yeah, one thing we've kind of done extra is like if somebody comes in and tests positive for the flu, we'll just give them a free out.
Right. I mean,
Yeah.
if someone is visibly ill, we're not going to make them sit in group.
I've done it.
Well, okay, I let them leave from group.
Depending.
All right. Well, I appreciate you guys. I can go cover my bases with admin now.
Good.
Any other coronavirus questions out there?
Oh,
We can
sure,
certainly
yeah.
address them because it is very relevant right now. So, alrighty. Well, why don't we? Are you ready?
I'm ready.
If I pull up, okay.
So I know we talked about stigma a couple of weeks ago. Katie did a presentation on stigma, and this is a little bit of a different specific twist on it. And as usual, I have too many slides and not enough time, so I'm not going to go slide by slide. So you are typically sent these slides, and you will have the research resources that you can review at your leisure. So I'm not going to spend a lot of time on the research, although the research is presented in the slides. So we are in a unique position as providers treating a stigmatized patient population that we have. Basically, our patients are stigmatized, and then we are also stigmatized as providers. So that's the by and against. And many of you who have started up medication-assisted treatment programs in your settings felt that early on, either by the community or in the agency or the program where you wanted to start treatment, because not all your colleagues were happy about you seeing patients and prescribing Suboxone for them, no doubt. So even in our setting, when we first started this, interestingly, I distinctly remember a mental health psychiatrist being like, I don't want those patients in our hallways. And I was like, oh, well, that's nice. And so there's a lot of provider stigma both against us and the patient population that we treat. So this is just an overview. We're going to talk about what stigma is and who's stigmatized, which I think people basically know. Who's responsible? How does it impact patients and providers? The research, which I will kind of cruise through, and then what we can do about it. So you guys know that stigma is really an attitude, behavior, or condition that is socially discrediting. So people are considered less than, or people don't want to be around them if they're stigmatized. And usually, especially with regard to addiction, it can really tip on the balance of beliefs about control and about cause and controllability. So if I believe that if you really, really, really wanted to stop doing that, you could, that's going to be stigmatizing rather than believing that you actually have a disease over which you have limited control. You have the responsibility of seeking treatment and being active in that treatment, but you do not have the choice of whether or not you actually contracted that disease. So language and terminology is really important with regard to stigma. We talk about person-centered or person-first language. And so that is, I'm not saying this individual is an addict I'm saying this is an individual with addiction. They're not an addict. So you put the person first. And that includes things like NAS baby versus an infant with NAS. So the person comes first in that person-centered or person-first language. And it has a very different feel to patients. And it also has a very different feel to providers, especially when we're training other people. It's especially important to use that kind of language because that is what our trainees learn. The research shows that worldwide addiction is the most stigmatized condition, both among healthcare providers, even more stigmatized than any other mental health condition, including things like schizophrenia. So this is kind of the vicious cycle of stigma, and it starts with labeling and non-person-centered language like addict. So that's a label. And then when you hear the word addict, you think of a stereotype of what that is, and one can conjure up, your own image of what that label kind of makes you think of. And then immediately there's this idea of that person is not like me, that person is not like my family, so there's an us versus them division, and then a loss of social status, that I am better than that person. And that results in discrimination and people being treated differently simply because they have been given this label. So who's stigmatized? Certainly individuals with substance use disorders. And if you guys have worked with families, families are stigmatized so that their friends no longer want to associate with them because they have a family member who has a substance use disorder. The family members don't get invited to holidays or parties. And so the family then has to deal with that stigmatization. And then individuals who are receiving medication-assisted treatment are also stigmatized, as we know, both by providers and family members and the community. And then we as providers also experience stigma. We are stigmatized for treating substance use disorders, although this has really changed. And if there's something good that has come out of the opioid epidemic, it is that I've in my lifetime, I feel like I am more valued as a provider treating individuals with substance use disorder now than I may have been, 15 years ago, because it's considered a great need, and many more people are actually interested in going into the profession. There's a lot of interest in addiction medicine. And then certainly providers who provide medication-assisted treatment are highly stigmatized, even more so because of the belief that we're dealing drugs or something. So who spreads stigma? Really anyone. So patients stigmatize themselves, so they feel that they have failed their families, failed themselves, that they're bad people. Patients often have tremendous amounts of guilt and shame, and that can lead to stigma. We've seen in the NA community that people in recovery stigmatize people who are seeking medication-assisted treatment or on medicine. In our own community, we've heard stories that people who are taking buprenorphine are not allowed to speak in meetings and are not allowed to work the steps, and so that is highly stigmatizing. Doctors or physicians stigmatize both patients and those of us who are using medication-assisted treatment as a treatment for OUD, and nurses. So I work with a lot of pregnant women and see the stigmatization of pregnant women by NICU nurses especially. NICU nurses are fierce advocates for babies, and if they perceive the mother to not have the baby's best interest in mind, simply by virtue of having used at some point during their pregnancy, or simply by virtue of being on buprenorphine, that they can be stigmatizing towards the mothers. Therapists can also be stigmatizing, so we need to look at our own biases about either medication or about certain patient populations. And then families, I'm sure you guys have all known patients who come in and say, I can't tell my mother that I'm on this medicine, or my family thinks it's terrible that I'm on this medicine and they're pressuring me to get off this medicine because they said it's just taking another drug. And then pharmacists. So we've heard stories about patients, either pharmacists claiming that they will not fill prescriptions of buprenorphine, or patients being not treated very nicely at the pharmacy once the pharmacist realizes what medication they are filling. So why reducing stigma matters is that obviously people are dying of this disease, and when they are stigmatized, they're less likely to seek help. And then if it's stigmatized, we're going to have trouble with the workforce shortage. So I'm going to fast forward through the research. So the general gist of the research is that substance use disorders are most highly stigmatized as compared to any other mental health disorder. That the finding on this one study was that perceptions of stigma actually predicted treatment completion for patients, so it impacts outcomes. And so it's really important that patients not feel discriminated against. And this is patients in treatment felt discriminated against by their providers. This was a national study that basically, this study is really interesting. Kennedy Hendricks, she's a stigma researcher, and so I encourage anyone who's interested to read more of her research. But it's, basically that everybody stigmatizes individuals with substance use disorders. And that, interestingly, primary care physicians had higher rates than the general, high rates of providers stigmatizing patients. And you guys all know, certainly public safety, criminal justice, housing, child welfare tend to stigmatize individuals with substance use disorders, and specifically patients with on medication-assisted treatment. So we're trying to get actually an echo working with the judges, talking about medication-assisted treatment to try and help provide them with some education and dispel some of the myths around that. So we're trying to tackle some of this in the various kinds of professional workforces. So I'm gonna keep going because I'm gonna run out of time. So specifically about medication-assisted treatment. So it's really grounded in this idea that medication, buprenorphine, methadone, the agonists are just substituting one drug for another. So there's been studies on that, and that the awareness that medication-assisted treatment is an evidence-based treatment and has been shown to work is pretty low. And so that was a survey about, what works, and nobody seemed to know that medication-assisted treatment was an effective evidence-based treatment. And that individuals with OUD using medications confirm that, they experience very high rates of stigma among lots of different people, including healthcare providers. So the good news, and this is directly related to why we want to have peers as part of our workforce and part of our treatment workforce, and encourage people to share their stories of success, is that there is some evidence to show that as clinicians work with individuals with opioid use disorder and with medication-assisted treatment, they begin to see people get better, and that has a huge impact on the negative stigma. So this really reinforces what we know to be true, which is people do get better. So again, the major things that influence stigma are this cause and controllability, what we believe about those things in connection with an individual and their ability to control their behavior, or whether or not we believe they caused their addiction. And when you talk with, so I would talk with a lot of CPS workers, when you talk with a lot of CPS workers, they absolutely blame the parent that they're working with, and they do not really often believe that addiction is a disease. And so they think it's a lifestyle choice, it's a moral failing, and that they are bad people versus they are sick people with a disease. So this is a quote from Alan Leshner, who's the former director of NIE and former director of NIDA. Addicts are not weak-willed, their brains are just held hostage. So we're all capable of doing small and sometimes large things to reduce stigma. Obviously, we have the most impact on our personal life and the people that we come into contact with. So I try and talk with my family about what I do, but they do not work in, my family of origin do not work in healthcare. And so they often are puzzled by what I do. So I try and talk about that with them, and hopefully they carry some positive stories into their own lives. Private, we think about either those can be kind of private at the private professional level, so in our own agencies, or that can be considered private or public. Public is, I'm really thinking about institutions. So one of the efforts we have here on our campus in Morgantown is we try and do interdisciplinary training of all disciplines: pharmacy, public health, dentistry, medicine, all kinds of folks around opioid use disorder, medication-assisted treatment and addiction in general, and they all go to these interdisciplinary courses together, and that's really going to impact things at the public level if we're infiltrating kind of the education system. And also the criminal justice system is another system we're trying to help along with regard to stigma. But it really becomes a barrier to acknowledging the problem, both at the individual level and at kind of the personal and the private level. Stigma towards individuals with addiction reinforces that misperception that the person caused their addiction, and then it decreases people coming forward and seeking treatment, as well as negatively impacts our ability to build a workforce to deliver treatment. This is a quote from Nora Volkoff. "In all my years as a physician, I've never met an addicted person who wanted to be an addict. People don't set out with this as a goal." So I'm gonna move. This was sort of an amusing cartoon I found. So this is like a doctor who's acknowledging this is a brain disease, right? But we don't necessarily want people to wear a t-shirt announcing that, because that's not necessarily the helpful thing. So people need to feel safe in an environment where they are going to talk about having an addiction or being in recovery, and that should be the individual's choice. A label that we force people to wear if they do not feel ready. People are really pretty good judges of when it's safe and not safe to share their stories. So combating stigma, really, education is one piece, educating people about the disease model, educating people that treatment works and people recover, and that relapse. There's a slide from a study where relapse rates are very similar to rates of other kinds of chronic diseases, like hypertension and asthma and type 2 diabetes. And there are many other diseases and chronic diseases where there is a behavioral component, and that's one of the reasons why addiction is stigmatized, because there's a behavioral component to addiction. You have to do something in order to develop the disease. Although in theory you could have the disease in a latent state if you never use a substance, but you wouldn't be symptomatic. And then language. So it was interesting how hard it was for me to stop saying clean, like how many clean days do you have? And I go back in some of my slides from a couple of years ago and I'm like, oh my gosh, I didn't change the language there. It took me about a year to stop saying clean, because I didn't see it as stigmatizing. But when you think about clean, the opposite of clean is dirty, and obviously dirty is stigmatizing if we're talking about someone's urine drug screen or their number of days of sobriety. So paying attention to our own language and changing that is actually really important. And it's not about being politically correct. It's about not perpetuating stigma. And it's different for me to talk about someone who has a substance use disorder than when they talk about themselves. When people talk about themselves, they can use whatever language they want. It doesn't necessarily mean they want other people to use that language. So if someone chooses to say, to introduce themselves as, you know, hello, I'm Laura and I'm an addict, that's their choice, but I'm not then going to call that person an addict. Personal witness is the other incredibly powerful thing, and again, this is where peers can be really helpful, is putting a face and a voice to recovery when it's safe and supported by professionals, that people come forward and really share their stories of recovery. And encouraging people to attend 12-step meetings, especially speaker meetings where they hear stories of success. And I always encourage students and anyone who wants to learn more about addiction and recovery to go to open meetings, and especially open speaker meetings, because they can be really inspirational. So this is a quote from Brene Brown. When we deny our stories, they define us. And when we own our stories, we get to write a brave new ending. And I thought that that was a really, that kind of spoke to how to move beyond stigma, is for people to really share their stories and own them. So as healthcare providers, we can certainly influence stigma in relationship to our patients by helping them reduce their own guilt and shame. And so that's really the personal or the private stigma that sometimes people talk about it. We certainly hear it among pregnant women, especially. They have tremendous guilt and shame around exposing their baby to substances, offering moral support and validation. So just saying, yeah, this is hard and this is real. So it's not fake when people say, you know, I went to a meeting and they told me I couldn't talk. That really happens. And so it's not always safe for patients to go to a meeting and announce that they're on medication, that's a real thing. They need to be careful about who they share that information with, because it is stigmatized in the recovery community in certain circles. Respecting confidentiality, certainly. Adopting a non-judgmental stance towards our patients and treating the patient with compassion like any other patient with a chronic illness. And by trying to help patients figure out how to advocate for themselves and how to protect themselves from being stigmatized, and whether that's making sure that they protect their own privacy in certain settings, or helping them to speak up when the cost isn't too high. Like helping them discern like what's safe and what's not safe. And then with healthcare providers, so talking to colleagues and coworkers about addiction being a brain disease, and doing education in the healthcare system in general. And so one of the things about medication-assisted treatment moving into family medicine or primary care settings is it really helps with that, because it moves it into the arena of general healthcare. Sharing stories of success, and then using non-stigmatizing language. And then ourselves, like being aware of our own biases and finding support. So we know that this is, you know, as we talk about patients who sometimes are actively trying to deceive us, it's hard, and we have a reaction to that. And it's important to talk about that on our treatment teams and in confidential settings, where we can give support to one another about how it's hard to work with a patient who's actively trying to deceive us, and what is that really about. That it's not, you know, not to take it personally, that that's not about us really. It's about them either protecting their addiction or being active in their disease. And I think that was probably it. Oh, and hope. So finding ways and stories to share about hope that people do get better. So I was really excited to meet the recovery coach. Well, Lois has sort of been in that role also at Cabin Creek, and to hear from all the folks who attended last Friday about people pursuing, you know, roles as recovery coaches and roles as stories of hope among their peers. I think that is one of the most important things we can do to reduce stigma.
Thank you so much. That was so excellent. I wanted to ask everyone, did anyone have any questions about Laura's didactic? I'll be sure to attach her PowerPoint to the recap email.
And I think the other, if we want to present some cases in the coming weeks or in general about, you know, experiences of stigma that we have either experienced as providers or we've seen patients experience or heard of patients experience, those can also be some of the cases that we put forth, and then kind of problem solve and brainstorm how to help people with those.
This is Jennifer. I thought I would just tell a short story of something that happened to me today. I didn't know you were going to present on stigma, and this was very good, and I've heard people talk about it before, and I think about it a lot. And I apparently about a month ago, I ran into an individual in our community who's in the legal profession, and told him that I was going to be starting to prescribe Suboxone, and he voiced some skepticism, and right then and there was an opportunity for me to just address stigma, okay, and to get just share with him a little bit about medication-assisted treatment. So I did. Oh, I saw him today, and he told me that I'm curious about the echo you're going to be convening, because he told me that what I told him that day made such a big impact on him that he's helping to convene a meeting with the help of our local substance abuse task force that we have here in Fayette County. He's helping to convene a meeting with law enforcement, people from the legal profession, and medical providers to talk about substance use disorder, and that he's been talking to people about the conversation that he had. So I was kind of blown away by that.
That's fantastic. Yeah. And it doesn't have to be a huge presentation. It can be a small conversation you have with one person that then talks to other people. So that's a great example of the small ways.
Yeah, I just told them the things had been learning. One quick question I have is about, and we may not have time, but is about confidentiality in the group setting. I feel like I'm still feeling my way, and my model for entering into this work is Angie Barker, who has worked with you all, and also the folks at Cabin Creek. Lois came and did a presentation a year ago. But it's such a different model of care than what I'm used to, being one-on-one in the room with the patient. And so when last week when I met the group that I was working with, I sort of I asked questions about how the medication was going and what were they doing in their recovery. And I also asked them a little bit about themselves, because it was the first time I had met them. But I really let them decide how much they were going to talk. And I wasn't sure, in a group setting where the where the chronic disease is substance use disorder, how much of their personal story is okay to talk about, and should that be driven by the patient and not by me? Another question related to that is, and I asked Angie this today, but I'll just ask again, the results of their urine drug screen from today, here you are in a group, and that seems to me that that's not inappropriate to talk about in the group, because that's why they're there. Is that on target?
Yes. So I think that is an excellent question, the general question about confidentiality, and even the specific one about how do we share urine drug screens. Can we bump that to the next echo? Because I think it deserves a conversation. And I'm sure that people have a variety of different experiences with that, because those of us who are therapists and we're trained in group therapy, it's like not a big deal. But for a lot of medical providers who have never done treatment in a group, it is very strange and very foreign and hard to navigate. And so, yeah.
Okay, that'd be great. It's part of the learning curve for me is the setting. So
yeah,
that'd be great. Thank you.
Jennifer, you can email